Topic for today's discussion is intrahepatic cholestasis of pregnancy. Reference is Green Top Guideline number 43, published in June 2022. So, what are the key recommendations? How will you diagnose the intrahepatic cholestasis of pregnancy? It should be considered in the pregnant women who have itching in skin of normal appearance and raised peak random total bile acid concentration of 19 micromole per liter or more. Additional laboratory or imaging investigation are not recommended unless it is associated with atypical clinical symptoms, the presence of relevant comorbidities, and an early onset severe ICP. Consider additional postnatal investigation in women who resolution of abnormal liver function test is delayed or does not occur. In previous guidelines, whenever the patient present with ICP, intrahepatic cholestasis of pregnancy, having itching, so in that case they will prescribe all investigation. They will advise that all investigation should be done. But in now recent guidelines, they advise that only whenever the pregnant patient present with itching and itching, along with that with no other associated comorbidities. So in that case, bile acid is enough to do alkaline ALT, and the other investigation is bile acid. Other investigation are not indicated unless otherwise other symptom associated with it, like steatorrhea, like jaundice, and along with that to exclude other causes of hepatitis B, C, and autoimmune condition. So in recent guidelines, they recommend that only bile acid ALT. First, you will do ALT bile acid. If they are normal, then you will do further investigation. Consider discussing the care of women with severely very or typical presentation of what appear to be ICP with the hepatologist. Confirm the diagnosis of ICP in postnatal period for at least 4 weeks after birth with resolution of itching and liver function test returning to normal. So postnatally, you have to, for confirmation, you have that the ICP is usually with pregnancy and it will resolve after pregnancy. So for that confirmation, you will repeat LFTs or bile acid after 4 weeks postpartum, and to check that if it is not normal, the bile acids and ALT are not normal, then you have to evaluate for further investigation. Advise women with isolated ICP and a singleton pregnancy that the risk of stillbirth only increasing above population rate once their serum bile acid concentration is 100 micromole per liter or more. So in that case, they say that with isolated ICP, the risk of stillbirth only increases when the bile acid exceed 100 micromole per liter or more. In women with a peak bile acid of 13 to 19 to 39, mild ICP and no other risk factor, advise them that risk of stillbirth is similar to the background risk. So the background risk of stillbirth is almost 2.8%. So it is normal when the bile acid is 19 to 38. It is the stillbirth rate is similar to background risk. Consider other option of planned birth by 40 weeks of gestation and ongoing antenatal care according to the national guidance. So if it is the bile acid is less than 90, then you have to evaluate the patient for any skin related condition. So you have to refer the patient for dermatologist. If it is more than 19 or 39, so it means that there is ICP. In women with peak bile acid 40 to 99, moderate ICP and no other risk factor, advise them that no risk of stillbirth is similar to background risk until 39 to 30 to 39 week. Consider planned birth at 38 to 39 week. In women with mild ICP, consider birth at 40 weeks, and with the moderate, you will consider birth at 38 to 39 weeks. In women with peak bile acid of 100 micromole per liter, severe ICP, advise them that the risk of stillbirth is higher than the background risk. Consider planned birth at 35 to 36 weeks of gestation. Advise women with ICP and a twin pregnancy that the risk of stillbirth is higher compared with a twin pregnancy without ICP. Clinicians should be aware that fetal ultrasound or CTG does not predict or prevent stillbirth in ICP. So it will not predict. So CTG is not a monitoring for to predict that the patient, the baby got stillbirth. So it is not a predictor for that. Usually the best thing is that for monitoring of that patient, that the patient should perceive her own fetal movement. So that is the best predictor Otherwise, CTG is not a best predictor. Advise women with ICP that the presence of risk factor or comorbidities such as gestational diabetes or preeclampsia or multifetal pregnancy appear to increase the risk of stillbirth because two risk factors coincide with each other. As already the patient is having ICP background, there is risk of background stillbirth. But if the gestational diabetes or other preeclampsia, other comorbidities associated, so the risk of stillbirth increases. So may influence decision making around timing of planned birth. So you have to decide. It's not as we have the target value for that in mild we will proceed the pregnancy up to 40 weeks, and moderate we can wait up to 38 to 39 weeks. But along with that, if the patient is having risk factors, any comorbidity, so the fixed gestation will not be in that case. In that case, you have to individualize the patient that whether she's having diabetes, preeclampsia, she may need early delivery. So in that case, you have to individualize. Advise women that there are no treatment that improve pregnancy outcome or raise bile acid, and the treatment to improve maternal itching are of limited benefit. Do not routinely offer URSO for the purpose of reducing adverse perinatal outcome in women with ICP. So in that case, previously that said that the URSO has a certain impact on both, that it reduce the adverse perinatal outcomes in women with ICP. But in recent guidelines, they said that they only improve the usually itching of the patient, but not improve the perinatal outcome. So these are the recommendation. Otherwise, the explanation is not needed. We will only just go through these tables, the tabulated form. This one is enough for to understand. So these are enough for your knowledge. So we will only do these type of the tabulated form. So then, first of all, will that what is gestational pruritus, what is mild ICP, moderate, and severe. As we have discussed that itching and peel bile concentration less than 19, that is gestational pruritus, and mild with 19 to 39, moderate of 40 to 99, and the other one is peel bile concentration of more than 100, so that is severe. How is ICP diagnosed? How should be diagnosis of ICP? The diagnosis of ICP should be considered in pregnant women who have itching in skin of normal appearance with raised peak random total bile acid concentration of 19 micromole or more. The diagnosis is more likely if it is confirmed that the itching and raised bile acid resolve after birth. So in that case, the itching is just usually it is the bile acid deposit in the skin that cause itching. So usually the skin is of normal appearance, but the itching is due to internally, that the patient feel that I feel the skin, the itching is due to the deposition of bile acid in the skin. That why the patient feel itching, and usually more prone that the patient is having in the palms and sole. They are more in that area. They feel more itching. If a diagnosis of ICP is suspected, carried out a structural history and examination so that other causes of itching and liver dysfunction can be excluded. So whenever the patient came as you with the itching and pruritus, these type of station came as an OSCE station, especially is in a short case, or sometimes the structure discussion came as a ICP, but usually short case came as the patient all having ICP. Usually recently in the rising of ACP is more increases in usually Pakistan, that every second or third pregnant woman presented with ICP. So in that case, the most probable that the station come as a short case. Usually the patient present with the itching and pruritus. So in that case, you have to take the detailed history. So you have to rule the risk out the risk factors in case you because the risk factors for obs cholestasis are that the patient is having previous history of obstetric cholestasis. The patient is usually the primary gravida more prone toward the obs cholestasis. Those having family history of obs cholestasis, they are more prone towards the obs cholestasis. So these you have to rule out these risk factors. And the other thing is that you have to rule other causes of pruritus and itching, that it could be allergies, allergic dermatitis, atopic eruption of pregnancy, and herpes gestationis in the gestationum, in which that there is itching, and along with that there is a painful papules on the whole abdomen, and due to any viral hepatitis, any other obstructive jaundice that lead to itching. So in that case, you have to take the detailed history to rule out other causes. And then you will proceed toward the examination. You have to check from head to toe, check her pulse, BP, temperature, and rule out any comorbidities, because it will aggravate further disease like gestational diabetes, having past history of any preeclampsia, and current she's having any PIH and preeclampsia. So in that case, you have to take the detailed history, and especially personal or family history of ops cholestasis, in whether she's having previous pregnancy having ops cholestasis. So these are the important points you have to ask in history, then make a diagnosis, and then after that you will detail examination and then investigation. So if you are suspecting that there is ICP, so you will need only alkaline ALT level, liver function test, and that's bile acid. If the bile acids are more, so your diagnosis will be confirmed that it is ICP. No need of further investigation. Offer repeat liver function test and bile acid depending upon the gestation and clinical context in women with normal blood result whose itch persists and no other cause is apparent. If resolution of itching associated with normalization of bile acid and LFTs during pregnancy, the diagnosis of ICP is unlikely to be correct. So, in that case, with having a normal bile acid and LFT, so the diagnosis would be not ICP. The diagnosis would be other form of diagnosis could be other, that it could be allergies, or it could be any polymorphic eruption of pregnancy, or it could be herpes. The other thing is additional laboratory or imaging investigation are not recommended in every woman but could be considered on individual basis. Consider antenatal testing only if there are atypical clinical symptoms, presence of relevant comorbidities, or early onset or severe ICP. So consider postnatal investigation in women whom resolution of abnormal liver function test is delayed or not occur. So usually the ops cholestasis patient present in third trimester. You have to remember this, that these type of patient, if the patient present is early in first or second trimester, then you have to rule out other causes, because in early presentation is less likely. The mechanism exactly is not known, but it could be due to in pregnancy there's bile stasis occur. So in that case, it aggravate the ops cholestasis. So due to bile stasis, the patient present with the intrahepatic cholestasis of pregnancy. So once the pregnancy, she can gone through the pregnancy, everything will be normal. But if there is underlying other cause, so it could be due to that lead to ICP. So you have to rule out in the patient present in early trimester with itching and pruritus, so you have to rule out other causes as well. So, what should specialist hepatologists would advise to be sought out? Consider discussing the care of women with severe, very or early atypical presentation of what appear to be ICP with the hepatologist. So, you will involve a hepatologist when patient is having a severe ICP and with a very early presentation or atypical presentation. So, you have to involve the hepatologist. So, what are the maternal and perinatal risks? So, this is very important when you are in counseling and also in a management point of view, that what are the risks that maternal and perinatal risk associated with ICP. Advise women that with ICP, the predominant symptom is itching. This can be severe, may fluctuate, and may markedly affect her sleep. You have to tell that this may affect her sleep. Women with ICP can have a higher chance of developing preeclampsia or gestational diabetes. So this one is also important, that those with ICP, they are high risk development of preeclampsia and diabetes mellitus. So they should have a BP monitoring and urine monitoring and testing for gestational diabetes according to national guidelines. So in Asian women, usually the NICE guidelines say that in every Asian woman, you have to do her a baseline at booking oral glucose tolerance test. So in that case, you must at booking you will do her baseline oral glucose tolerance test, and in that case, in ICP you have to check her at every visit. You have to check her BP and along with that urine for proteinuria to exclude preeclampsia, because with ICP there increased risk of gestational diabetes or preeclampsia. What is the usual postnatal resolution? Confirm the diagnosis of ICP in postnatal period at least 4 weeks after birth, resolution of itching and liver function tests resulting to normal including bile acid. So usually the bile acid after pregnancy with ICP, it usually normalize within 4 weeks postnatally. So you have to do a baseline testing after 4 weeks to exclude that the disease have been resolved. Then after that, what is the risk of stillbirth? As we have already discussed that those with ICP and singleton pregnancy, the risk of stillbirth only increases above the population rate once their concentration reach to 100 micromole per liter. So with 100 micromole, the risk of stillbirth is higher than the background risk. Otherwise, with the mild and moderate, it is still in the according to the background risk. But with 100 micromole, the risk increases. And also that goes with ICP and twin pregnancy, the risk of stillbirth further increases, because in twin pregnancy usually the more chances of congenital abnormalities, miscarriages and stillbirth rate are more in twin as compared to singleton pregnancy. So those with along with ICP and those along with twins, if she is having mild ICP, the background risk is increases because she is having twin pregnancy and along with that mild ICP. So these are the points you have to remember. Advise women with ICP that the presence of risk factors, comorbidities such as gestational diabetes mellitus, preeclampsia, multifetal gestation appear to increase the risk of stillbirth and may influence decision around making timing of planned birth. Advise women with ICP and a twin pregnancy that the risk of stillbirth is higher compared with a twin pregnancy without ICP. As we have discussed that in that case, it will be increasing. So they said the national stillbirth rate from 28-week gestation for 2015 countries contributing to these ICP data varies from 0.18 to 0.72 depending on the country. So the UK stillbirth rate was 0.29 in the UK, but obviously the Pakistan rate are a bit different. But in UK, as I've already told that 0.29% risk of stillbirth rate with ICP. So they have at different level. They have given you that national UK stillbirth rate from 20.29%, and with mild ICP 0.13%, 3 per 2, 310, and more with moderate ICP 0.28%, 4 per 1,412, and severe ICP 3.44%, 18 per 524. So in that case, the risk, the background, they both are correlate to the background risk. The background risk is 0.2, but in the severe ICP, the background risk increases, that is 3.44%. What is the risk of perinatal morbidity? Advise women with moderate or severe ICP that they have higher chance of both spontaneous and iatrogenic preterm birth. Sometimes the SBA came as that with ICP, what are the higher chance that with moderate or severe ICP, what are the perinatal morbidity? So in that case, increased chance of both spontaneous and iatrogenic preterm birth. Advise women with moderate or severe ICP that they have increased chance of having meconium stain amniotic fluid during labor and birth. Advise women with moderate or severe ICP that their baby is more likely to receive neonatal care. So in that case, you have to tell the patient. How should women with ICP can be monitored? Review women with ICP within a consultant-led maternity unit. So they have to be booked in consultant-led maternity unit. What maternal monitoring should be advised? For women with ICP, consider repeating liver function test and bile acid after 1 week. This could be your SBA. That how much is the frequency to repeat the liver function test, that is after 1 week, and then determine the frequency on the individual basis. So if it is increasing, so in that case, you have to individualize. Sometime monitoring we need after third day, after second day. So it will depend upon the bile acid level. Then after that, what fetal monitoring is advised? So clinicians should be aware that the fetal ultrasound or CTG do not predict or prevent the stillbirth in ICP. Women advised with ICP to monitor fetal movement and present for immediate assessment at their local maternity unit if they have any concern. So you have to tell the patient that she should be very vigilant about her fetal monitoring, about her fetal movement, because it is a good predictor. Otherwise, CTG and ultrasound are not a good predictors for a reduced fetal movement. What is the role of during treatment of ICP? What impact on maternal symptom, maternal biochemistry, and fetal outcome? Advise the woman that there are no treatment that improve pregnancy outcome or raise bile acid concentration, and treatment to improve maternal itching are of limited benefit. So they said that they are the role of drug, there is no such role, no treatment that improve the pregnancy outcome, bile acid or concentration, and they have a limited benefit. So in that case, because the patient is having having itching or pruritus, you have to give something. So in that case, you will prescribe topical emollient. Consider topical emollients such as aqueous cream with or without menthol added to ameliorate skin symptoms. So you have to prescribe that for to relieve her symptoms. Antihistamines. Consider antihistamine agents such as chlorpheniramine, particularly at night, although the effectiveness of this treatment is uncertain with women in ICP, but for it, sometimes the patient in these cases may work. And URSO do not routinely offer ursodeoxycholic acid for the purpose of reduce adverse perinatal outcome with women in ICP. So in that case, they have a trial that URSO has no improvement in her check, no improvement her bile acid or pregnancy outcome. They are as the same, but it will just only symptomatic relief like with the itching and pruritus relief with the ursodeoxycholic acid, because they have a certain mild effects on the bile acid. So evidence from randomized control trials show that there is no reduction in adverse perinatal outcome in women with URSO compared to women in the placebo group. So there is a small around 5 mm on a linear 0 to 10 mm itch scale with 0, no itch or 100 worst imaginable itch. Reduction in maternal itch in women taking URSO. Women and clinicians consider that reduction of at least 30 mm on the itch scale would be clinically relevant and worthwhile. The majority of women would therefore not consider this a useful treatment. It remains possible that some women and pregnant people itching may reduce with URSO, but it is not clear how such women might be identified. A recent secondary analysis of large trial could not be considered on cohort based on the bile acid concentration or itch who would benefit. So, a systemic review individual participant meta-analysis of URSO include 4 randomized controlled trial of over 8,000 women with a primary outcome of stillbirth and composition, secondary outcome of stillbirth and preterm birth. So, URSO had no impact on the primary endpoint. The primary outcome was stillbirth. So it will not have any effect on the stillbirth. The stillbirth are same. Spontaneous preterm birth under 34 weeks was not reduced. Women taking URSO versus 6 by 36 women taking placebo. Spontaneous preterm birth under 37 weeks was reduced in women taking URSO compared with. So in that case that with the under 37 weeks the spontaneous birth will be reduced, and under 45 they will no effect. So in women with bile acid concentration 40 micromole per liter or more who are 34 to 36 week gestation, URSO may offer some benefit in reducing the late preterm birth. However, with other circumstances where preterm birth occur, it is not clear that this reduction result in any benefit to the baby. So the optimal starting gestation and doses regime are unclear. Some women and pregnant women with bile acid of 40 micromole or more may wish to take URSO with a review to prolong gestation, but this does not prevent stillbirth. The advantage to do is to be less clear, especially for those with a bile acid of over 100 micromole per liter. So overall, these studies randomized controlled style that they have no impact to improve perinatal outcome, no improvement on the stillbirth rate, and no improvement. Usually, in one study, they said that those were under less than 37 weeks they prevent the late preterm birth, but otherwise early preterm birth like less than 34 weeks they have no effect on that. So for a symptomatic purpose, they have in some patient they improvement in itch or pruritus, so for that you can prescribe, otherwise it have a no role. Do not offer other agent for treatment of ICP outside of research studies or individualized specialist treatment. Is there a place of vitamin K use? Consider maternal vitamin K only if appear to be reduced absorption of dietary fats, presence of steatorrhea, or evidence of abnormal PT if coagulation studies are performed. So in that case, when patient present with ICP, you will do a baseline coagulation test like PT. If it is deranged, then you will prescribe vitamin K, or if the patient is having steatorrhea, so in that case, you will prescribe vitamin K. Otherwise, vitamin K is not recommended in ICP. So you have to remember these 2 points, that sometimes the SB may claim that in which 2 cases you will prescribe vitamin K. In that case, you will when there is steatorrhea or coagulation studies are impaired. How should women advise on timing or mode of birth? As already will discuss the mild ICP at 40 weeks, and consider planned birth at 38 to 39 weeks with the 42. We'll consider, it's not a confirm that we will consider, we can proceed the pregnancy up to 38 to not more than with the moderate ICP. At least she should be, if at 39 weeks she is not deliver, you have to do induction of labor, because if you are proceed this pregnancy beyond 39 weeks, then there is chance of stillbirth. So consider, if the patient by self goes into spontaneous labor at 38 weeks, that is well and good. If it is not, then you have to do induction of labor. So the other thing is in 100 micromoles you will consider at 35 to 37 weeks of gestation. So in that case, you will if you are planning 36 to 37 weeks with the ICP of with the severe ICP with a bile acid of 100 micromole per liter, then in that case you will do a steroid cover for the baby. Advise mom that presence of comorbidities appear this may induce decision making around timing of blood. So, if the patient is having a background of any preeclampsia, multifetal pregnancy, so you have to decide the mode of delivery according to the situation. At mode of birth, advise women that ICP in itself does not impact their choices around the mode of birth, and the decision should be based on usually obstetric practice for the woman. So it is not a baseline, it is basically on obstetric practices. Then monitoring in labor. Offer continuous electronic fetal monitoring to women with peak bile acid of 100 micromole per liter. In that case, you will do continuous monitoring. There is insufficient evidence for against continuous electronic fetal monitoring with peak bile acid below 100 micromole. A shared decision can be made based on comorbidities and preference. But in our setup, if the patient is, because as a risk factor of ICP, there is risk of stillbirth. So in that case, we will do continuous electronic fetal monitoring. So they advise that according to guidelines, 100 micromole per liter. In that case, you will do continuous electronic fetal monitoring. Advise mama that the presence of risk factors appear to increase the risk of adverse perinatal outcome, that these conditions themselves may necessitate monitoring during birth, or in condition with ICP may influence decision making around monitoring in labor. Advise women that meconium stain liquor is more common in moderate and severe ICP, and this will influence decision making around continuous electronic monitoring. So in NICE guidelines, when we will discuss the intrapartum management of intrapartum care in labor, in that case, that one of the indication for CTG is that when there is meconium stain liquor. So you have to tell the patient that if otherwise in mild moderate we will not do continuous electronic fetal monitoring, in severe we will do continuous electronic fetal monitoring, but with the moderate there is a meconium stain liquor, then in that case we will do continuous electronic fetal monitoring. So one of the indication for CTG is meconium stain liquor. Analgesia in labor. Offer women with uncomplicated ICP standard analgesia anesthesia options. So anesthesia are safe, you can give analgesia. Third stage of advice, there is no evidence increased risk of PPH if they have uncomplicated ICP. Only if complicated ICP like PT, INR are deranged, so in that case PPH risk are increases. Otherwise PPH risk are not increases. What follow-up should be offered to women who have had pregnancy affected by ICP? So, for women who have uncomplicated ICP, follow up should be arranged at 4 weeks after birth to confirm resolution of ICP. Advise that they should anticipate itching and raise maternal bile acid concentration to resolve after birth. So, you have to tell that usually normally up to 4 weeks the ICP will resolve. If it is not, then you have to evaluate for, patient for further investigation. So, what are the future contraceptive advice? Advise women that ICP does not influence their choice of contraception or hormone replacement therapy. For women with ICP and previous cholestasis secondary to combined OCP estrogen containing contraception, advise them to use progesterone only or non hormonal methods. So, women with ICP and previous cholestasis due to COCP. Sometimes the COCP can cause cholestasis in pregnancy. So whenever the patient is having previous cholestasis due to OCP, so you have to not advise OCP. In that case, you will advise non-hormonal methods or to use progesterone only pill or non-hormonal. In women with previous ICP requesting HRT, consider offering if there is no other contraindication to use. If the patient is having previous ICP, so in that case you will to rule out that there is no contraindication, then you will to advise them. So all the women with pregnant discussion about the method of contraception and continue early postpartum day. This should be that health benefits, spacing pregnancy, medical condition and pregnancy characteristic contraceptive choices such as venous thromboembolism risk factor, breastfeeding, the reliability and benefit of long-acting reversible, and the additional use of condom is there is of STIs. So, UK-MEC for levonorgestrel early implant and can be restriction in women with history of ICP. So COCP can be used with the women with ICP provided they do not have a history of contraception related cholestasis. So you have to advise COCP in that case when the in previous history that the COCP is not related to the intrahepatic cholestasis is not due to COCPs. So you have to prescribe COCPs. It was previously thought that women with a history of ICP may have increased risk of developing cholestasis when using estrogen containing hormonal contraception, but this is unlikely for the majority of the women. So, in 2016, that estrogen containing methods outweigh and the women those choose due resolution of itching and liver function and bile acid returning to normal should confirm before commencing this method. Advise women to attend to review if recurrence of itch and abnormal liver function tests occur while using COCPs. Dutke be give a category diagnosis of contraceptive related cholestasis. So previously guidelines that you will not offer contraception in the form of the best option is you will not prescribe COCPs. So in that case, recently they said that these guidelines that if she's her LFTs and bile acids are normal and no she's not having any previous history of estrogen with the intrahepatic cholestasis due to COCPs, you have to prescribe the COCPs. But after 4 weeks still she is having the LFTs and bile acid adurine, so you will not to advise COCPs. How should women be cared for in future pregnancy? Advise women that history of ICP that have increased chance of recurrence in subsequent pregnancy. Perform a baseline liver function test and bile acid with booking blood investigation. So the recurrence is increases. Almost that there is 90% risk of recurrence of OPS cholestasis in next pregnancy. So you have to advise the patient that in next pregnancy a baseline booking LFTs and bile acid should be done. So these are the important points that we have discussed. If you have any queries relating to the intrahepatic cholestasis, so there is some tables from the TOG article. I will make a short videos of that.